honor to invite Dr. Sarita Bajaj ma'am, former professor and head of medicine at MLN Medical College, Prayagraj. She will be delivering her talk titled Unveiling Obesity, Embarrassing the Present, Shaping the Future. Please welcome Dr. Sarita ma'am.
Namaste. Thank you, Ashutosh and Pallavi, for the invitation. I'm happy to see a lot of people here. And of course, it's a pleasure to come to Varanasi. So I think we're shifting gears. The previous talk was supposed to be the first talk of the morning, but I think it was shifted. I'm back to obesity again. I hope there will be some important take-home messages from my talk, apart from those related to the molecule. So you can see how old obesity, the disease per se, we have data from 30,000 BC. And this is the earliest example of obesity in an art form, the old Stone Age era. So it's nothing new. The only thing is that we are now talking about it so much because of the recent molecules that have come in. And I think the nomenclature of obesity as a disease has made a sea change in the approach to management. That is the new ABCD or adiposity based chronic disease. What I'm trying to do here is give you a perspective of the old and the new, and most of the data that I am presenting is from the Endocrine Society guidelines. So this is, most of the data, like I said, will be from the guidelines. We are aware of it being a pandemic. I'll come to the ICMR NDIAB data in a minute, and I'll show you the regional variation and the national risk score. The World Obesity Federation score has given India a 7 on 10 with an urban prevalence of more than 25% across multiple states. So this is the data that I was referring to. It was a privilege to be part of the ICMR NDIAB study, and this was in NDIAB number 17, in which we showed that the projections for metabolic disease prevalence in India for generalized obesity, you can see 254 million, and obesity at 351. And we are ranking almost at 100 as far as being prepared for the management. You can look at the GDP, which is the economic impact in our country, and add to that is childhood obesity, which is a really, really dismal picture. As far as the state-wise representation is concerned, you can see that both generalized and abdominal obesity, maximum in Puducherry, least in Jharkhand. So this is the data which I showed you for the country as well as for the states, the maximum and the minimum. In 2011, we published this data on school children. So there are almost 40,000 children here. Prayagraj or then Allahabad contributed about 12,000 children in public schools and private schools. And you can see there was a whopping number of children with diabetes at that point in time as well. In Delhi, the overweight or obesity up to almost 33%. Prayagraj was about 20%, with an overall of 24%, much more in the metros as compared to the rural areas. And if we look at abdominal obesity in school children, abdominal obesity was significantly higher in girls, in metros, in private schools. So we are no better today The only thing is now what we have started doing is we have gone back to the schools. So I am running a diabetes education foundation for almost a quarter of a century. So at that time, under the foundation, we had done this study with school children. So now, since 2025 August, we are going back to the schools and we are again collecting data to see what is the difference. So this is one school, again one of the urban schools which we went to in August, and this is a convent which is again in the urban area. This was in November, which we tried to club with World Diabetes Day. As you can see, everything's blue, and we've tried to make a circle, which is the typical, it's not all blue because the colors of blue are different here. But we are trying to show the circle here, which represents World Diabetes Day. So this is unique to South Asia. You're aware of the thin fat obesity, that we are, as far as BMI is concerned, we may not be obese, but we are centrally obese and we are at more risk of the metabolic complications. So metabolic, mechanical, mental, I've tried to list them all over here. The enormous comorbidities which are associated, not to forget the monetary implications of management. So it is a real world challenge, undoubtedly. Now, interestingly, we all keep on saying that BMI is not a good measure, but we do not have any other measure to fall back on as of now. And you can see how, I don't think anybody would recollect using the term Quetelet index. Fair enough? We are all saying BMI, but this term is attributed to Adolf Quetelet. Unfortunately, we are not using that term anymore. So just to give you a bit of a historical perspective over there. Undoubtedly, weight maintenance is a challenge. That is why the newer molecules that have come in are ideally for lifelong. They are lifelong. But will that be sustainable in the long run? That remains to be seen. Yes, we have data up to 4 years that yes, the weight can be maintained even after discontinuation. But for how long? Eventually, we fail as far as lifestyle is concerned. And if we were following lifestyle all these decades, in other words, you should maintain your BMI, your waist circumference, what you have between the age of 20-25. If you can maintain that lifelong, I think that is the best treatment that you can do to yourself. Just look at the cumulative effect of small daily calorie excess. From half a kilo to up to 6 kilograms a year. That much difference it makes. And more than 90% of Indians do not engage in purposeful physical activity. In fact, whenever I give this talk, at the end of the talk, I make sure that everybody gets up at least from their chairs, because you would have been sitting for a minimum of 1 to 2 to maybe more hours. So just getting up. So even if you place your chair when you are examining a little bit away from the table, so at least you get up to write the prescription. Even that is exercise in itself. And this applies to us. This is a bitter pill. 20% of doctors are obese, 53% have diabetes, and 24% are hypertensive. And it is linked with the wealth as well. You can see from the poorest to the richest, from 2%, 2 out of 100 to almost 20 out of 100. And there are several reasons why this weight regain, because the system tends to defend a higher weight, making weight regain is common after weight loss. Okay, so there's a weight loss phase and there's an early weight maintenance phase, which leads to the risk of weight regain. Now, the algorithm everybody is aware of. The other day, this woman came to me. She was a good 150 kilograms. And she's coming to me for her thyroid. Fair enough. That's absolutely fair. So it's very difficult to tell 150 kilogram, or how do you ask this particular question? I mean, you need permission. Okay, if they have not come to you for obesity, even if it's 180, 200 kilograms, you do not have a right to prescribe anything. I'm sorry about it, but that's true. And you know that the terminology, we do not use the term patient any longer. It's PWO or PWD, people with obesity, people with. So we cannot use that term. So the ask factor is most important. Then to assess, advise, agree. So you have to have the goals in mind as to what is the percentage weight loss, and then assist with the drivers and barriers. So the first hurdle is to accept the patient, to agree to fall into your trap, if you want to call it that. So I've given the BMI ranges here. I'm not very happy with that from the Indian perspective, because we keep on harping that we are not BMI, we are BMI normal, but centrally obese. So should we apply the same BMI to our populations? Well, that is a question we'll still need to address and have more data on that. So these are the 5 pillars of lifestyle which are well known. We know that weight loss following lifestyle is not sustainable for the long run, and this is a typical tug of war of weight management. These are the approved anti-obesity medications. So if I ask you to put your hands up, everybody here may have, most people would have used Orlistat. Liraglutide, we never had 3 milligrams, so off-label it was being used. We do not have the phentermine topiramate combination. Yes, semaglutide, yes, tirzepatide, but again, naltrexone, bupropion is not available, right? The only thing is, subsequently, what is being thought of is that after you discontinue the GLP-1 RAs, so there are studies going on, can you continue with the oral agents? Of course, oral agents, oral GLP-1 analogs are on the pipeline as well, but subsequently, with a non-GLP-1 RA, can you continue long-term management? Are the studies which are in the pipeline. And now the current AOMs or anti-obesity medications are giving you as much weight loss as with bariatric surgery. So these are next generation GLP-1, which orforglipron, wonderful, efficacious, safe to use, non-refrigerated, orally available, non-peptide, small molecule, and it improves metabolic health. As you can see, in the phase 3, there was a decent amount of weight loss which went up with as you increase the dose. But retatrutide, you can see up to almost 28% weight loss. With the WOMAC score, that is a 100-point score for osteoarthritis, going down to 0 in 75%. So you avoid knee replacement. I think that is absolutely wonderful. Maritide will be once a month injection. So there is so much exciting data to look out for. These are the 5 C's of choosing. You have to look at the contraindications and cautions, the comorbidities, the cues, the combinations, and the cost and the coverage. Now, in the talk on MASLD, it was very nicely shown, 5%, 10%, 15%, right? Here you can see across board, even with 5% weight loss, we have improvement in all these parameters. And 5% is easily doable with lifestyle. Lifestyle does not ever go anywhere, whether it's diabetes management, MASLD management, or obesity management. That always remains one of the important pillars. That the more the weight loss, the better the remission, for example, of type 2 diabetes, obstructive sleep apnea, and GERD in males. So this is just to show you with pharmacotherapy, what is the weight regain, bariatric surgery. Again, there's weight regain, lifestyle modification there is. And you can see the boomeranging and the explosion of the GLP-1 agonists in the market for type 2 diabetes. as well as for obesity. Ensuring weight maintenance, like I say, is very difficult but doable. And one should encourage weight loss beyond traditional exercise as well. So this is the data we published last year to show that yes, any workout, whether it's Bollywood dance, whether it's Zumba, all of this helps. And yoga, of course, is also beneficial. Social management is important. And even if you exercise for 1 to 2 days in a week, it works as far as weight management, but not for the metabolic benefits. For metabolic benefits, you have to do it at least 5 days a week. And of course, the digital environment. So to be able to exercise, true, you need a good environment, which is very well shown in this study. And the home environment, the digital environment is a big no-no in that regard. And I think I'm a big fan of Michelle Obama's. When she was First Lady, this is something she really focused on. Let's move. And previously we said 10,000, 10,000. Now we've even come down to 7,000. We've brought the step down count. You can see very recent publication. Look at the enormous benefits of just 7,000 steps a day. So I'm going to stop here. I think my time is up. I won't go into all the other, extra things that one can do over and above this, but I would like to stop here. Thank you. Thank you very much. Please.
Ma'am, I want to know, we are taking care of the lifestyle and the diet and physical activity. You're right. It's very difficult to attire them to a profile for a longer duration, and some of them are doing it excellently. I just want to know that the medication which we are proposing, because now it's in the WHO agenda also, that we can, they have approved the anti-obesity medicines. So I want to know that right now we all are talking about weight. So what is going on with respect to their percent fat, their muscle mass? Are we evaluating, or do we need studies on it so that we can work more research on that particular part, not just weight?
No, there's definite work going on. Dr. Nitin Kapoor's group in Vellore, they're doing a lot of work on sarcopenia. It's a 3:1 ratio. So you lose 3% fat and 1% muscle mass. As it is, apart from aerobic, you're supposed to be doing resistant training, resistant exercises as well, which need to be emphasized more now if you are prescribing anti-obesity medications. Undoubtedly, they're both aerobic and resistant, and balance. The third is balance, right? All three are extremely important, especially with the medications that we are giving.
So, ma'am, what is the rate of weight loss with the medication part? Is it different for every individual?
Very variable.
Because
there's some 5% maybe total non-responders to semaglutide, but they may respond to tirzepatide. There may be again non-responders to tirzepatide who may respond to semaglutide. Then the step up. You're supposed to start with the least and step up slowly. So if you're not able to, for example, go up from 0.25, fine. Not able to tolerate 0.5, then you have to step down again, right? Similarly for tirzepatide, you go up 5, 2.5, 5, 7.5. Whichever dose patient is not comfortable with, again you step down. So step down, step up, stay, but you have to eventually reach the full dose. And that might take up to 6 to 10 to 12 months. So the rate of weight loss is absolutely unpredictable. And like I said, from non-responding to up to 28% weight loss you can get with some of these molecules.
Sorry, I'm asking one more, ma'am. Ma'am, with weight loss drugs, plus if we do nutritional management strategies, I think we have a better outlook, and we'll get a better output.
Small, frequent meals, not spicy, not fat-based, not sugar-based. So a lot of protein, fiber, everything has to come in place I think it's tougher. Like I said, maintain your ideal body weight, what you have now if you're in your 20s, and keep it there forever. That's why we're going back to the schools. They are the population we want to target. Primordial prevention. We've not been doing it at all.
Ma'am, Anup Mishra sir has already reduced the BMI cutoff now. It is 23. And if you are with disability, then you are obese class 2 and obese class 1. It's totally different now. The things are changing with time.
Thank you. Thank you so much
for your comment.
Thank you. Thank you.
Ma'am, good afternoon. Ma'am,
Sorry, yes, please.
ma'am, any role of retatrutide?
Sorry?
Retatrutide, ma'am.
Of course, I spoke about that. That is the molecule which we are looking forward to. The Triumph 4 data I showed.
Indian scenario, ma'am. Indian scenario.
Of course, 28.3% weight loss. And like I showed, osteoarthritis 75%. WOMAC score back to 0. Wonderful. We don't have to do knee transplantation. I think that's too good.
Good afternoon, ma'am. Ma'am, I want to ask, with the increasing use nowadays and the availability and the changes in the price, the dilemma which we face in younger patients, say 20 to 35, who will come to you, they qualify by BMI, say 28 to 30 BMI. They ask you,
30 without, and 30 just obesity,
Yeah,
27 with comorbidity.
Yeah, so they qualify with BMI, say above 30. And how do you handle when you personally feel that, I mean, there are scenarios where we feel we don't need to give this drug to that young patient. So do you face this dilemma clinically? And if yes, how do you handle that and how do you counsel them?
I've given you the 5 A's, right? So first you would ask, is the patient willing? Like, I'm trying to convince this 110 kilogram person. He comes to me 110, then 106. Then he said, no, I don't want. And he knows all the agents, but is not willing to go on it. And I know he needs it. He's got MASLD, and he has some other metabolic issues, but he's just not willing to go on it. And he's got 35, 40, the ideal person. But if they don't agree, you can't give it.
Ma'am, my question is the other way around. If you think the patient doesn't need and he needs to do lifestyle more, and you don't want to give the drug, do you face this also?
I would not give it. They can get it from any extraneous source. Or gym people are prescribing. I think any Tom, Dick and Harry. I wish there was a women equivalent for Tom, Dick and Harry. I think I'll have to look up maybe. Yeah? Still Tom, Dick and Harry.
Thank you.
What is about the lean obese?
Sorry?
Lean obese. Lean obese.
Lean obese, you mean BMI normal,
Yeah.
but waist circumference is increased.
But
Yeah.
Uncontrolled diabetic, maybe on OHA, multiple OHA.
And not controlled.
Not
Would I give a
controlled.
GLP-1? Yes, I would. There are two different things. Management of obesity and management of diabetes. Yes, we are not looking at the BMI when we are talking about diabetes management. Yes, I would give it.
You'll give it.
100%. And that is indicated. I mean, it's not me saying it, it's science talking.
Ma'am, you had said at the beginning of the lecture that at the end you ensure that everybody stands up, and by asking questions, most of us have indirectly.
Anyway, okay, while there are questions are being asked, please stand up and let's do some exercise.
Yes. I think we should take it further, Dr. Ashutosh Pallavi ma'am. मैम ने जो कहा है कि it should start from school and mobility as well, even for all of us, and we have to start ये वाराणसी declaration में अगर आप इसके लिए जगह बनाएं, it'll be very nice. And we all are there to contribute. Respective cities में, states में जाकर के we should ensure that the school children are, in our own respect. हम सबके बच्चे हैं. We all are facing the same issues, etc. We should take it further. Thank you, sir. Thank you, ma'am. Thank you.